All right, we'll get started as people are kind of filtering in here. So welcome, everybody. My name is Kate Gleason-Bachman. I'm with the National Healthcare for the Homeless Council, and we are very pleased to welcome you to our fourth session of this learning collaborative on nurse-led care. If this is a session that you're returning to, welcome back. If this is your first session, welcome. This is the last session, but it's going to be a very good one. So we've had a great few sessions so far. We're really excited to be closing out this series. We have some great speakers again for today from our faculty. And as we have in the other sessions, I'm just going to lead us through a little bit of housekeeping, and then we'll do a little bit with Mentimeter to find out who's here, and then we will dive into our presenters, and we'll have some time for questions and discussion at the end. So next slide, please. This is a disclaimer. Excuse me, this learning collaborative is supported by the Health Resources and Services Administration. However, the contents do not necessarily represent the official views of, nor an endorsement by HRSA, HHS, or the U.S. government. Next slide, please. So this learning collaborative is put on by the National Healthcare for the Homeless Council and the National Nurse-Led Care Consortium. It's been a really wonderful collaboration, and we have been very lucky to have two faculty groups join us from two health centers, from Circle the City in Phoenix, Arizona, and from Colorado Coalition for the Homeless in Denver, Colorado. So we've also been really lucky to have all of them across all these four sessions sharing their expertise with us. Next slide. Just very quick, this is, our last session, but a learning collaborative is meant to be participatory. So we really encourage folks to ask questions. If you want to ask them in the chat, we'll have some time for questions at the end, and to really engage in the activity. And we're really glad that you're here. Next slide, please. Through the Nurse-Led Care Consortium, we're able to offer nursing continuing ed credits for these sessions. Each session is one contact hour. So in order to get the contact hour for today's session, you need to participate in the entire activity, complete the evaluation, and also achieve an 80% pass rate on the assessment following the session. And the poll evaluation will pop up at the end, and we will put the link to do the knowledge assessment in the chat at the end. Next slide, please. Very quickly, our agenda. We'll do some Mentimeter introductions. We are going to hear this is about sustainability and funding, this final session. So we are going to hear from Colorado Coalition for the Homeless and from Circle the City about what this looks like and some strategies, how they're doing this at their organizations. We'll have some time for Q&A, and then we'll do our evaluation. Next slide, please. And I will turn it over to my colleague.
Thanks so much, Kate. Hi, everyone. It is so great to be with you all here again today. We are going to once again return to our Mentimeter. I am dropping in the chat the direct link, or hopefully this is all familiar to everyone. You can use the QR code if you have a handheld device, and we will move along quickly through these. Our first is our little pin a dot on where you are. Apologies for the Mentimeter visual technical difficulty, but I'm glad to see you all can still put in. It gives us a chance to see where you are joining us from. And we just love this because it has been such a wonderfully diverse array of experiences, of places in the progress of having nurse-led care, across the country. And we are very grateful. We know that it is very difficult to take an hour out of your day to attend something like this and to be as participatory as you all have. And we're just so grateful for that. So thank you all for being here, and love having so many different states represented. It's really exciting. So a little on topic for today, we wanted to hear from you all. How is your nurse-led work currently primarily funded? That might be a loaded question. It might be something that you're not sure of, and that is a-okay. But it's helpful for us to hear what people are kind of operating with. And wow, what a great little dispersion of this. So looks like we have some reimbursement only, no, excuse me, we have some grants only, quite a bit of reimbursement and grant combo. I think that's the nature of health center work in general. So I'm not surprised to see that represented. I think so much of what we do, and especially nurse involved work, has this, some people use the term braided funded model, but you know, meaning more than one source. But really nice mix, and absolutely no worries for those of you who are unsure. That will not make you any less able to participate in today's conversation. I certainly know, as the 10 years that I worked at Baltimore Healthcare for the Homeless, I very rarely knew what it was that allowed me to, and my team, to do my work exclusive exactly. So I really appreciate that. This is an open-ended question in general. Just a chance for us to hear from you all, thinking back on the 3 sessions you've had, knowing that we have one more remaining today. How do you plan to use the information from this collaborative in your work? It may be about advocating for nurse-led programs within your organization. Maybe there's a nugget that you have picked up from a particular session that really resonated with you. And so I'd love to hear how you envision this coming into play. Implementing population health visits, absolutely. I know nurses in Baltimore were really instrumental in leading our population health work. Developing new ways to have nurse work at the top of their scope. You're right on topic today. That I know is something that Andy's going to talk a little bit about, and be more active in nurse-led work to finesse business plans, proposals, growing nursing visits, advocating for broader code training. Love to hear that. Some work in the, not just of the people who are in your building, but actually how to leverage the systems you have in place better, and the importance of doing that data work. Our friends at High Tech will be thrilled to hear that answer. Advocate for at the executive level, explore reimbursement options, really expanding the nurse role, new grant funding to fund new initiatives. I love this. And I hope for those of you, the answers also maybe gave you other ideas. And it'll be something really exciting to share out with others, to see this was kind of the sentiments. And hopefully these are planting seeds in your brain of, if that wasn't what you had taken, but it might now be something you're thinking more about. So without further ado, I am going to hand it over to my friend Andy Grime from Colorado Coalition for the Homeless. And I take it away, Andy. Thanks so much for being here. We're really glad to have you with us.
Thanks so much, Katie, and good afternoon, everyone. I'm Andy Grimm from the Colorado Coalition for the Homeless. My title is Chief Integrated Health Operations Officer. That pretty much means I oversee all of the non-clinical health center operations for the coalition. We can probably go to the next slide. Yeah, there we go. Just a picture of our recuperative care center, which you've heard a lot about in the session so far, and that I'll talk a little bit more about today. I do use he, him pronouns. I've been with the coalition for just over 7 years in a pretty similar role that's evolved over time. Also serve as our health center project director, so I'm primarily responsible for all of our relationships with HRSA, and do a lot of work with our base grant funding, as well as all of the other funding that comes in to support our health center program. And I am also privileged to be the current president of the council board of directors. So really happy to be with all of you this afternoon. Let's go to the next slide. So I gave a little bit of an agenda here. I'll start with, I think you've probably all heard about the coalition several times now through the course of this 4 sessions. So just a reminder that the coalition has been around for over 40 years now. We were founded as one of the original 19 healthcare for the homeless programs that came out of the Robert Wood Johnson Foundation pilot program in 1984-85. And so we celebrated our 40th anniversary last year as an organization and a health center. The organization has expanded since then to not only provide healthcare for the homeless, we also have a small amount of public housing primary care funding. So we'll do a lot of work within our own housing. So we also build, develop, and operate affordable and permanent supportive housing around the Denver metro area, and then provide the supportive services and healthcare services and other things that are necessary to keep people supported and successfully housed. And so I'm going to talk today about some of the grant, contract, and other kinds of revenue that the coalition has used over the years to support nursing care and nurse-led care in particular, including some things that are more in the past, so as well as some very current and recent awards that we've been able to leverage. And I think all of this is going to give a good picture that what Katie said about bringing together all kinds of different funding streams and funding sources and reimbursement methodologies is really the only way that healthcare for the homeless programs are able to do all of the amazing things that we do. We can't count on reimbursement alone. As Teresa, one of my colleagues, and others throughout the session have shared, in many states, including here in Colorado, nursing services are not directly reimbursable for FQHCs. However, those services do get wrapped up into our cost reporting. And so depending on the methodology of your state and with the Medicare cost reports, we do get some indirect reimbursement through our encounter rates for nursing services that are part of our overall cost-based reimbursement. But in many places, as we've learned, nursing services are not able to be billable in that we submit a claim like we would for a primary care provider. So we can go to the next slide. So this is going to take us back in time a little bit, but this is one of the primary grant awards that CCH has leveraged over the years to grow and develop our nursing program here. And so this was a really amazing opportunity for us that actually started back in July of 2018. And so this was a 4-year award we received from the HRSA Bureau of Health Workforce. So that's an important distinction that I want to point out. The health center funds that we all, or most of us, receive as part of our base grant funding, that's all, and the health center program in general is part of the Bureau of Primary Health Care at HRSA. And so many of us are very well aware of the base grant funding and the other supplemental funding and the new access points and other awards that come out of the health center program and the Bureau of Primary Health Care. But the Bureau of Health Workforce at HRSA is also a really important source of potential grant funding to support additional work, especially in these workforce related areas. And so in addition to this one that I'll talk more about, CCH has also received awards from the Bureau of Health Workforce to support behavioral health provider training and internship programs. And so one of my key takeaways here is that make sure you're not just paying attention to funding opportunities from the Bureau of Primary Care, but that you're really looking at those health workforce opportunities to help potentially support nursing services and care. So, and I will also say that there have been multiple different programs over the years under this broad umbrella of the NEPQR acronym, which means Nurse Education, Practice, Quality, and Retention. You know, HRSA always loves a really good acronym. So that's the name of an overall program that HRSA issued several funding awards in over the years, some that are currently active that have looked at different particular subsets of the workforce. So our particular award was focused on a registered nurses in primary care training program. So this was a $700,000 annual award. So a pretty large award when it comes to supporting health center operations. And this allowed us to develop a 4-year training program that recruited and trained nursing students and current RNs to practice to the full scope of their license, really with a focus on community settings like healthcare for the homeless, with some emphasis there on chronic disease prevention, mental health, and SUD conditions. So you can see here that the goals of this program in general were to achieve a sustainable primary care nursing workforce. And so this allowed us to partner with schools of nursing. And I think there's one more slide. I should have brought up my own slides, I suppose. Oh yeah, here we go. So here are the program goals of that program over the 4 years that we had it. So not only did this allow us to partner with 3 schools of nursing in the Denver area to bring in nursing students to create this multi-site training program. So we exposed them not only to our traditional outpatient Scout Street Health Center location, but also to our mobile clinic and our street medicine program and all of the other different areas that CCH provides healthcare services in. But it also allowed us to provide some training to our own existing nursing staff and to build skills around precepting among our existing nursing staff. So our own RNs served as the preceptors for these students coming in. And it also allowed us to have a placement coordinator to help us with these rotations. And so it was a really great partnership that has, since then, it really helped to show and demonstrate the value of nursing services as part of our overall integrated care model. And a lot of what we've learned, including those relationships with the nursing schools, have persisted through until now. Obviously, the end of the award was right at the start of the COVID response. And so that had forced us to shift some things, but also allowed us to do some things that we didn't necessarily anticipate related to nursing care. So telemedicine was actually a stated goal of the program starting in 2018. And who knew we would be doing so much with telemedicine then as a result of the COVID response. So I just share this as an example of a HRSA funded opportunity that really allowed us not only to increase the skills of and training of our own internal staff, but created a pipeline for us of interested candidates who were then able to join our own nursing workforce. And so this was a really cool opportunity. Unfortunately, this, like many other grant awards, does have a finite expiration date. And so I think the important thing always is to keep in mind how you are going to sustain certain elements of this once that funding goes away. And so what this allowed us to do is really learn lessons and build out relationships and some of the infrastructure and training that then we made shifts in how we were staffing and what model of care we were using to be able to leverage those lessons learned when the funding was no longer there. So yeah, I think we can go ahead to the next slide. So this is a much more recent example of how we're leveraging HRSA funding. So many of you might be aware that HRSA released a couple of expansion opportunities last year. There was the expanded hours opportunity and the behavioral health service expansion. So we actually proposed a pretty unique expansion program that HRSA is actually still trying to figure out how to document correctly in the EHB, but that's a different adventure. But we propose to use the Expanded Hours Award not only to expand access at our fixed site shelter-based health center location at the 48th Avenue Health Center. So we have right now a 5-day-a-week shelter-based health care site where we staff an integrated care staff, including primary care and nursing with some behavioral health and dental. But we've always identified that like being in a shelter-based setting from like 7 to 4 is never going to reach all of the people that are utilizing that shelter. It's a 24/7 shelter in Denver, Denver's largest. And so people are coming and going to work and going to appointments and other routine needs during the traditional business hours often. And so we're not reaching everyone in the shelter. So what we proposed was to add additional time there on a Saturday and do a Saturday clinic with nursing support, as well as add some additional time in the evenings. And so that was more of a traditional, like, let's add hours to a fixed site. But what we also proposed was adding additional hours to our already pretty robust street medicine program. We are going to now have providers on our street medicine team 5 days a week instead of the previous 3, with additional robust nursing support. In many ways, our street medicine program is nurse-driven. And so this allows us to expand into more and more days of street medicine as well. The really great opportunity with HRSA awards compared to some other funding that we receive is that HRSA encourages you to bill Medicare and Medicaid for all possible services while leveraging the award to pay for those billable providers. That's pretty unique, that you're able to get paid to fund the salary of a provider who you can then also generate revenue on. So those are always opportunities that you want to keep an eye out for. Certain city foundation and other awards want you to reconcile Medicaid revenue that you might be making from billable providers and somehow not leverage the funding to pay for those services, but that is something particularly unique to HRSA funding. And then these are ideally to roll into ongoing base grant funding after year 2 if certain requirements are met and if ongoing funding is available, which is always uncertain in these times. So do we want to go to a question now, or should we wait until the end?
Your preference.
Let's go for it now. And I'm going to actually make April help me out here a little bit, because so April Kroll, our director of nursing at CCH, is joining me as well. So the question is, how are the street teams nurse driven? Can you tell us about the workflow and team?
Yeah, absolutely. I'll try to make it super quick for like a giant project. So the street team is nurse driven because the manager of that program is a nurse, and it kind of has been since the inception of it. So the only full-time staff that work on street medicine are nurses. We have multiple providers that work on street. We have multiple MAT peers. We have multiple medical assistants, but they're all like 1 day a week or 2 days a week, whereas nursing is the only full-time staff, and that's their whole job. It's the nursing team that manages all the referrals. It's the nursing team that helps select, like, what are we doing with the days and how are we gonna balance the micro community sites, the hotels, the camps, the RVs, like where is the need and how are we gonna meet that? And then in conjunction with like the integrated health leadership, it's that nursing manager that's trying to drive strategy about what is the street medicine program. So there are programs like some of the ones in California, like USC and UCLA. Those are very, very, in Boston, like they're very, very primary care focused. Like you have a panel of patients, you intentionally set out to find them, you have scheduled appointments every 3 to 4 weeks. You are doing primary care in the street. And there's other programs that are far more like urgent care, that are, we go out, we find who we find, we're going to treat the cellulitis, we're going to treat the pneumonia. We may not see you again for a year. It just depends on when we stumble across your camp again. And those are both totally valid ways to do street medicine. You just have to have somebody driving the strategy of like, which one are we and how do we transition from one to the other? So that's a lot of what the street team does. And the workflow of the team, like again, in a very quick nutshell, we're trying to bridge those 2 different models. We started very much as urgent care, And we're really trying to provide more comprehensive care on the street, especially now that we have psychiatry that's coming out with us. And so a lot of the workflow is intentional follow-ups that we saw somebody and we want to try to find them again. We want to try to continue meeting some need that we've identified. And then as a team, we come together and we identify usually no more than 4 or 5 people who require like really intensive follow-up. Those are folks that we're going to try to find once or twice a week. Maybe we've had situations where we literally every day deliver a single pill in order to try to get this person stabilized. We have other people that we meet on the street twice a week to do wound care. So you can't do that for every patient. There never will be enough bandwidth, but the team kind of decides like, these are the people we're going to devote this heavy resource use to. So you have those intentional follow-ups, and then we do a lot of like, we're out, nobody's been to the northeast side of Denver in the last 3 days. We're headed up north today. The team tomorrow is going to go south. So then we just try to expand out and capture everybody we can. So hopefully that answers that.
Thanks, April. I think we can go to the next slide. Oh, look, I put a picture of them in here. I forgot about that. So this is the amazing, or some of the amazing street medicine team and what April just described. All right, now I'm going to talk a little bit, and you've all learned about the Recuperative Care Center, so I'm going to go through this real quick because I'm going to specifically talk about the revenue that is generated from our recuperative care bed contracts and how we leverage that to support the nursing care in our recuperative care center. So yeah, we have a 70-bed recuperative care program at the Stout Street Recuperative Care Center. We serve about 800 unique patients annually with our integrated health model. And as Mariah has previously described, that is also a nurse-led and managed program here. It's the coalition. You can go to the next slide. So these are really the elements, the non-billable elements that we have to figure out how to fund as part of recuperative care. Are the room and board and the safe space that requires cleaning contracts and laundry services and serving folks 3 meals a day in a kitchen. And so many of those services in most states are not billable in any way through a sort of respite or recuperative care benefit. That's certainly evolving, as we've talked about a little bit in these sessions, but right now in Colorado, the way that we combine revenue streams to be able to fully support our recuperative care center is through a combination of billable visit reimbursement and then contracting with our hospital system partners to help cover the room and board component that is not paid for through the Medicaid reimbursement. So next slide. So yes, we really take a look at the financial planning and budgeting, both looking at the clinical and non-clinical components of the program. So the clinical components provide access to primary care, behavioral health, dentistry. So all of those kind of traditional integrated healthcare services. We have what is essentially a primary care outpatient clinic within the recuperative care center building where folks go to receive their primary care services with other services happening around the building. But there's also 24/7 nursing services available. And so when those are delivered outside of that billable primary care visit or other encounter, those are not directly reimbursable. And so we have really done an amazing job of engaging with hospital systems. We partner with every major hospital system really in the entire state of Colorado, and also have a contract with the city and county of Denver for recuperative care beds. And that revenue provides about $2.9 million of the overall operating revenue for the recuperative care center that pays for all of those things that don't get paid for by our Medicaid encounter rate. And then we also leverage foundation grants, philanthropy, and really use all of these sources to build what is needed for the recuperative care program. Next slide. So this is the slide that we use to justify the bed reservation costs to hospitals. There is an incredible cost savings if you look at what we charge a hospital for a per bed per month cost, and what keeping someone in the hospital in an inpatient setting costs the hospital on a daily basis. It's nearly, I always tell people, it's essentially costs the same for a 30-day bed reservation, 30 days of care and recuperative care compared to 1 night of an inpatient stay. That's about the cost ratio there. So these are just some of the things that we do. So yeah, you can go to the next slide. So this just really illustrates that we save hospitals about as much per day as it costs for an entire monthly bed contract. All right. So now I'm going to transition and talk about something that April just referenced in talking about our street medicine program when she said micro-communities and hotels. Which are perhaps more unique sites of care that we serve. And so last year in January of 2024, Denver got a new mayor that really initiated an effort to break up the very large encampments that had existed in many areas around Metro Denver, and to move in a very organized collective fashion, sort of one encampment at a time, into a non-congregate shelter hotel site. So the city has master leased several hotels in the area that are serving as non-congregate shelter for this purpose. And then there are also several sites that are called micro-communities that look more like tiny home villages, if you were familiar with that. So a really different structure there. But we leverage both our mobile health center as well as the street medicine team that April referenced to provide services to the patients in these hotel and micro-community sites. That includes primary care, behavioral health, dental, psychiatry, and nursing. We're also supporting a lot of the interagency kind of care coordination with the city as well. And so when we recontracted for 2025, the city recognized the critical importance that nursing had been playing in our 2024 response, and actually made the ask to us to increase the amount of nursing staff that we were able to use and leverage to help with a lot of this care coordination work, and just recognizing how critical nursing is to our street medicine and outreach efforts. And so we are currently working. The challenge, I will just say, with a contract like this is that they often want to contract for a year at a time, which can make it challenging to be able to hire a staff member with the promise of a long-term engagement. So we're always just careful to make sure that when we're hiring for specific contracts like this, that we are open and honest up front, that these may be time-limited positions. That is the challenging part of contract work. It's not always sustainable, but it is a way. So this contract is paying for those 100% of those RN salaries and benefits, as well as indirect, to be able to support this project. So it is a real opportunity for us to be able to keep and add additional RN staff to our team with financial support. All right. This is my last slide here. So this is one of the weirdest things I've ever participated in and most unique ways that we've gotten funded. And so these events exist in several places around the country. So this is called the Prime Health Innovation Challenge. We've participated several years, but actually the award I want to talk about, or the funding we got, was in 2018. So that's why I'm showing you 2018. But essentially, this is a challenge where startups who are interested in health technology, particularly in how that might intersect with more of the community health and kind of non-for-profit spaces of healthcare. It matches up those tech pioneers, entrepreneurs, startups with nonprofits in the healthcare space to be able to match award funding that these organizations receive when they win this challenge, to be able to actually then implement the ideas that they presented in the challenge. And so I've served as well as a few other CCH staff as judges for these events in the past. And then when the organizations who win, they're given prize money, and the goal is to match up health centers and other healthcare providers with the startups to spend down their award money. And so CCH used this to implement a telemedicine backpack pilot program that helped us learn more about how we might leverage technology when we go out and do home visits in our own properties, as well as on street medicine. And while we're no longer using the same technology that we implemented in 2018, because 7 years later, it did give us a really great opportunity to trial out some technology that our nursing staff could leverage. And so while this didn't pay for nursing staffing, it helped us pilot a nurse-driven program and pay for the technology component of that. So next slide, we'll wrap it up here. So I think these are my top line messages. Get on every HRSA mailing list you possibly can where award or funding opportunities are announced. Not just the Bureau of Primary Healthcare, get on the Bureau of Health Workforce. There's other HRSA bureaus that award funding to health centers. Become familiar with your local and state foundations. There are, like, Colorado has a Colorado Health Foundation. Many states have a state health foundation that provides philanthropic support and grant awards. Develop relationships with those program officers. They always love to learn more about what organizations in their communities are doing. I think for contracting purposes, develop relationships with your local and state governments and other healthcare systems and entities that contract out for healthcare services. That's been a way that CCH over the years has been able to fund services and that may not have otherwise been able to be reimbursed. And then I think really get creative and look at these healthcare and technology startup programs. There's health tech incubators out there, and partner with the people that have the money to be able to really implement cool, new, innovative ideas and practices. So I think that is my last slide. Please feel free to reach out to me if anyone wants to talk more about any of these particular experiences that we've had or anything else, and appreciate everyone joining today.
Thank you so much, Andy. I so appreciate having you here, your wisdom, and sharing these kind of braided opportunities, and that reminder that we are kind of operating typically in one space in the HRSA sphere, but there's a lot of other really great opportunities at the city, state, and even federal level. So really appreciate that. We're going to hand it over to Tara from Circle the City to chat a little bit about their programs.
Hello.
Tara, you can take it away.
Thank you. That was so great, Andy. Thank you so much for sharing. I learned a lot. I'm sure other people did as well. We can skip to our next slide. That's just an introduction to everybody that's been here. So I'm here representing Circle the City with our team. And just we've done introductions. We've kind of shared that we're down here in Phoenix, and I just wanted to do a quick snapshot of the impact we've had here in the last year. We are a smaller company, a little over 250 employees, but we're working on growing. We have 2 medical respite centers. We're expanding to a 3rd, and we have our mobile units, street teams, and 2 outpatient clinics. So it's just a quick look at what we've done here in the last year. You can move to the next slide. This is just a quick overview of our billing. We shared this previously. Majority of our money does come from our base grant. Our PPS rate, as Andy indicated, is more focused on providers, but we're looking at the other commercial and charity, focusing on some of those opportunities. So we can move to the next slide. Our funding is our base grant of $4 million. One of the other things I wanted to focus on, we'll talk a little bit about, is our 340B drug pricing program. Like I said, we're a small company, but this is going to be a big change for us and something that can help us with our expenses for patients. And then our grants and donations help to subsidize our capital items, food and beverage, those things, like you said, were not covered in our rate for our medical respite centers that operate 24/7. Next slide. Looking at the funding, we're going to focus on a little bit more is our donations, 2.4 million, our base grant, 4.1 million, other grants that we have throughout the company, $2.8 million, and then our other income from the money that we have on hand is listed there. Next slide. One of the things we wanted to focus on, we did share our grant-funded RN care coordination position. This was a grant that was written by our chief medical officer at the time, Dr. Sandoval, looking to follow up on care coordination and transitions of care for our patients, focusing on our underserved population. We do have a lot of patients that really struggle with high utilization in the hospital setting. And so the goals of this grant, we received $135,000 that will end this December. We want to increase the number of patients that have an encounter with our care coordination nurse to help them establish a good relationship with our services, reduce the number of hospital utilizations amongst our patients. We want to get rid of that revolving door for our patients and increase the number of patients that are introduced to our wraparound services. Our provider support visit is the number one way that we focused on sustainability for this grant. We can talk a little bit more about, we already spoke about that, but we can talk a little bit about our current PPS rate. If we have 2 extra provider support visits a day, we can earn $672 a day. Those visits would be nurse-led, start with the nurse, and then the provider would come in at the end of the visit, as we discussed previously. This would lead to a reduction in time spent by the providers and an increase in patients that can be seen by that provider. And so per year, that would equal roughly $129,024, which would be really close to that $135 that we received for that funding, so that we can keep this initiative going and keep focusing on our patients that are in and out of the hospital, making sure that they can follow up with the providers that they need to see. Next slide. Our McKesson 340B pricing, this is a newer program for us. We've decided to partner with a pharmacy, and how this works is much like other FQHCs, we do provide a lot of medications. Just today I'm at the respite, so I do apologize if any overhead paging happens while I'm doing this. But just today we had a new patient enter. He had stored all of his medications over at our shelter and went over there today, and they were all gone, and his wheelchair had been given away. So we had a patient enter with no medications, and he had just refilled them about 2 weeks ago. So now we work to provide him those medications. And so what 340B pricing is, it allows qualified health centers to purchase discounted outpatient medications at discounted prices. So we have currently the upper floor of one of our outpatient clinics is housing our Maxor pharmacy that we've partnered with. We're able to get those medications discounted at 20 to 50%, so that we can pass those, so we can keep those savings and keep serving more patients and help them with those medication needs that they have. Covered entities that can do this are community health centers, hospitals, other healthcare providers that serve a high proportion of low-income patients. So this is definitely something that's really been a big help to us as a group to help our patients get the medications that they need. So I wanted to focus a little bit on that possibility. Next slide. I wanted to look a little bit at a charity-funded project that we've had here. We have the Women's Wellness Project. You can see we have a mobile, up at the top is our mobile mammogram that we work with. And then we have below that, it's a contract. And then below that, we have our mobile medical unit that we use. This started in 2022 with free mammograms and 2 events and a food truck and offered cancer screening. And now we're up to 4 events yearly in March and October at both of our sites. And you can go to our next slide. We can share a little bit more about what this looks like in the last, since 2022, the last 3 years, we've had 192 women screened at no cost to them. This came from our community, from a private funder who said, I'll fund this project as long as nobody knows who I am and you don't share that. So we've decided to respect that, and we've increased our activities every time we do this event. Now we have community donations and vendors. We had at one of our last events, we had volunteers come and do haircuts for our ladies. They really, really loved that. That was a lot of fun. We also, like I said, have a food truck that comes in so we can do meals and allow our patients and non-patients, actually, it's members of the community that are facing or experiencing homelessness, can be involved in this project. We had a lot of community support, and we've been able to increase our screenings to include cervical cancer screenings and STI screenings. So we do screening. So just to answer this question really quickly, so if what we do is we have a screening protocol and we have a provider on site that's writing the orders, as well as nurses. It's a nurse-led program that are completing the forms and asking the screening questions. This is for screening only. So if we do have patients that have any kind of concerns with discharge or anything that would look like it would need a deep 3D or more intensive mammogram, they would be referred back to our outpatient clinics where they could set up, and since our provider's right there, they could say, hey, I have time in my schedule for you next week. Can you come follow up with me and we'll get you over to a different mammogram that you need for the screening. So typically we'll talk to them and ask them if they've had a mammogram in the last year. And if they let us know that, they've already had it or they don't qualify, we'll still hand them one of our little backpacks and say, thank you for coming and being a part of this project. But typically we're able to catch those. And then we've been working on follow-up. After that mammogram event, all of the records go to that provider. We're able to make contact with, working with our shelter system, alert system, to reach out to patients who've had any kind of abnormal results. And so we do try and get our follow-up on that. Since the beginning, I've been there providing education. The last 2 events I stepped back from, but this is me out there with that bottom picture is me with my education breasts. They have small, teeny tiny little lumps in them. They have larger lumps that can be found on self breast exam. And it kind of shows in a real life situation what the difference is and how small of a lump we can find on mammogram. We provide a lot of education about where most lumps are found and family history and things that you can do to decrease your chances for cancer. It's just a fun event. Everybody gets involved. And it's a really great opportunity to treat some patients that we may not be able to see. It's very hard in general to get our patients to agree to cervical. So we do have, we host these at our outpatient sites that have showers available in our clinics. So that's another thing that we don't want our patients to stress about. That's very challenging for a lot of our patients. So we do offer that as well. Next slide. I wanted to focus a little bit more on our community support. We do rely a lot on our community support. We have an amazing development team that does help. And some of us have connections to people in journalism, so we'll reach out for any kind of stories on things that we're doing here. And that really gives back with our community support. We have big events and small events that are covered by the media. At the last council, we sang in our choir, created a choir for that, and little things like that. We got on our local NPR station for that, and some of those things just bring up our name and get us some more recognition. And one of the things that we have is our shoebox circle. And when we started, Sister Adele, our founder, who's over there, started out working on the streets and meeting patients where they are. That continues to be our mission. And as she was doing her rounds and taking care of patients, she noticed there were so many needs. And so she started carrying around a shoebox with her on the street and helping out with, we all know the Arizona heat. People need shoes here. It's very dangerous. We see a lot of burn wounds. And so she started carrying that around, and to honor the beginnings of Circle the City, we continue to have a shoebox circle, which is monthly donors that donate. And then we get newsletters. I'm a member. We get newsletters that share the latest events and things that we're using that funding for, and it helps with that support each month, so we can kind of rely on those donors, and then they can come and volunteer if they're interested. And this helps us with specific needs that aren't covered by HRSA grants, that aren't covered by grants in general, move-in costs, clothing, shoes, all different kinds of needs. Patient comes in and they're going to lose everything if they don't pay for their storage, right? So what can we do to help them get in there, pay some fees to get all their stuff out and help them find out? So that's our charitable giving. Kindness kits we've been given from the community, and that helps us. We've donated over 20,000 in the last year. Helps us with our patients out there and possible patients. Just one way to share more of our mission. Next slide. And I'm not an expert in grant writing, so this is for all of those who are like myself, who are interested and want to know what they can do. Number one thing is be aware of funding opportunities. Talk to people about what we need and what that would look like. Things that you want to make a case for uniqueness, importance, and immediacy. Looking at what do we need? Why do we need it now? What does it look like that's different than the other programs that we have around? And then you need to provide data as nurses. We do that every day. And we like to focus on sustainability after the grant. If we started a new initiative, it's amazing and wonderful, but now the grant funding's gone away. Does that initiative stop? What can we do to keep that great work moving forward? The next slide. This is not an adequate list of resources, but it's a start, a jumping off point. Regional resources, as Andy said, look at your local foundations. Candid Foundation Directory can help you to find grants in your area, grant writing training, and the National Council of Nonprofits can link you to your local state council, and they can help you with grant research tools. So that's all I got. But every one of us can be involved in grant funding and other projects every day. So thank you guys very much.
Thank you, Tara, so much. And yes, a great reminder that you don't have to be great at grant writing and that you don't have to be the expert in all of these things, but you can often tell the story, which I know more often than not is really an important component of the grants, that they need to hear what it is like to work with an individual and to really to bring to life what is on the paper and the data in particular. So thank you all to our incredible presenters. Before we do our last minute wrap up things, I am going to launch our poll so that you all have a chance to do that. And I encourage you, please, if you have any other questions, we'll have 2 or 3 minutes at the end. I do just want to touch upon a couple last minute housekeeping things. So here we are at our last session. I can't believe it. You will get all of the items, the slides, and the recordings sent out via email likely next week. It generally takes a day or two for us to get it up on the YouTube channel. We are, for those of you who might know, we are preparing for our big conference in May. So our communications team is doing all sorts of things. So bear with us, but you should have that early next week. There in that email, it's going to be chock full of really important things. There is an additional final evaluation. This is for us kind of a reflection on all 4 sessions. We do really ask that you take time to complete that. It is so helpful to us and so important for us to be able to bring these opportunities. As we have mentioned in each session, this is HRSA funded, so we need to show if this was hitting the mark, if this is something that is useful, if these learning communities are things that you like. It is really important for us that we have your feedback, because we can only guess otherwise. So please take the time to do that. The recordings will be available for 2 months. So I encourage you, if there's anything you want to go back to, you'll have the slides in PDF form, but go back to that. There in this email, there will also be a Google form if you happen to miss any of these Zoom polls. And that's important because for each CE certificate you need, if you want the CE hours, you had to be here in person, you had to complete the evaluation and then complete the CE quiz. I know Kate just put into the chat the final quiz for this session. That assessment link. We will send all of those out again, as well as the forms necessary to be able to get all of those pieces. So the CE quizzes will be closed by Monday morning. So please take the time to do it. That is your chance to get those CE credits. So take the time. It is 5 questions. I really encourage you to just do those now before you forget. And you have the link in the chat right now, and the other 3 are in the email that I sent out as the reminder. And then finally, thank you to our incredible faculty. Thank you to our co-facilitators in this, the National Nurse-Led Care Consortium. They have just been incredible partners for the past 2 years. We were excited for another year of work with them, but it's really been exciting to bring you these different learning opportunities and to feature our incredible faculty from Colorado Coalition for the Homeless and Circle the City. It has been just, as a social worker, I love working with nurses. I always say nurses make the world go round. It certainly was the case in my health center that they were the first people I turned to. They were my partners in troubleshooting and problem solving and tracking down the clients that we were trying to see. And anytime I had encountered something on outreach, I would always go find a nurse to say, and they'd be very quick to come out and say, let me get eyes on it, or let's, always up for an opportunity to engage someone new. So I really hope this has been a helpful learning opportunity for you all to argue the case, to build the ideas and the layers of the way to offer nurse-led care in your communities, in your programs. I know that you all are doing it anyways, because nurses are leaders by nature. And so hopefully this has provided some opportunities to think of different ways to fund these programs, to build them, to grow them, and to meet the needs of the people you serve. Thank you all for being here. We are here if you have any last minute questions, and otherwise, thank you so much for participating in this learning collaborative.